All right, we can go ahead and get started. We might have a couple stragglers coming in. Thanks everybody for joining us and being flexible with your schedules. We had to reschedule this one for this month because I was out of town last week, so thank you. So we'll start off with some introductions and who's on the call. I think most of you guys know me. I'm Erin Montgomery, one of the nurse coordinators for our outreach program here at Riley. And I have Dr. Abulavdil with me.
Hey guys, I'm Kamal, one of the peds intensivists and work with the outreach team. So I'm sure we have seen each other in person before or in the future, hopefully again.
Okay. So I think we have one person on the phone, 317-718-8540. Who's that?
Hendrick, and it's Lauren Pavlitich, Jennifer Miller, and then Dr. Farman.
Hey guys.
Hey. Hey.
Hello.
Michelle Rusi is also on the phone.
Okay, great. Welcome. And who else we got? Don't be shy.
Hi, this is Dawn Sullivan-Wright. I'm a clinical nurse specialist for Community Health Network's emergency department.
Great.
Hi, I'm Emily Green. I'm the nurse educator for the Community North Emergency Department.
Okay.
Allison and Mark are here from Community Anderson.
Thank you. Did we get everyone? Anyone else? No? Okay. All right, we'll go ahead and get started. So I think almost everyone here has been with us through the whole time, but just to kind of reiterate, the goal of doing these echo sessions is to provide education and to really create kind of community of providers and caregivers to share knowledge and experience. So everything about this is educational environment for learning and collaboration. As most of you know, we're recording all of our echo sessions. So by participating, you're consenting to be recorded. If you guys have any questions about that, please just feel free to contact me. And you are eligible for 1 hour of CME and CEU for attending. And so here's the instructions. And if anybody needs help or can't jot it down fast enough, I can send these slides to you in email. So just let me know. But here's the event ID for this session. And you just have to claim it by 11:59 tonight. And here is the learner statement and disclosure information. Okay, so our previous two sessions were focused on pediatric sepsis in the ED. We talked about recognition and then treatment. So today is really going to be kind of guided by what you guys want to chat about, what you're currently doing, what you'd like to do, and if there's any ways that we can help with that, and kind of hearing what everybody's doing to treat pediatric sepsis in their ED and some of the resources they have. You want to talk about it? Okay.
Yeah.
So this is just a quick review. If you guys missed any of the first two of the sepsis talks or weren't able to see the recordings. So why did we pick this topic? Besides, it's a topic that a lot of people want to talk about, but there's about 75,000 cases a year with a 10 to 20% mortality, and there's a higher mortality in less than 1 year of age with comorbidities. Average length of stay in the hospital is 31 days, and the cost is more than $40,000. And then, of course, there's, that's supposed to be short, not short, short-term, long-term, and functional outcomes. And data is very, very lacking in this area. So what is our clinical presentation? Again, this is just kind of a quick review of what we've already talked about. Altered consciousness, confusion, psychosis, tachypnea, jaundice, tachycardia, hypotension, all these things I'm sure are sounding very familiar to everybody. Oliguria, decreased platelets, increased PT, APTT. And then just a quick review on cold versus warm shocks. This is something that's pretty pertinent to pediatrics since, especially in the emergency department, when you're seeing adults in septic shock, they're typically presenting in warm shock. That's what I'm told. I don't have any experience with that because I'm a peds person. Where your pediatric patients will typically present in cold shock. So what's the difference? In cold shock, they're cool and clammy, or in warm shock, those patients will still be warm and they're kind of flushed, you know, red faces. In cold shock, their pulses are going to be weak and thready, where in warm shock, they're bounding, and then they're going to have a really narrow pulse pressure in cold shock versus warm shock, where they have a wide pulse pressure. So what are our treatment strategies in pediatric sepsis? Fluid resuscitation, which we'll talk a little bit more about, obviously starting antibiotics and removing the source and monitoring. A lot of this isn't that different from how you treat adults. And then obviously support and organ support. So a lot of you have seen this before. This is kind of the, I guess, flow sheet, for lack of a better word, that we've used in the past. And you've got your times on the side that shows your ideal time that you're going to initiate these treatments. So obviously your first initial assessment, you know, 0 minutes, you're going to hopefully recognize decreased mental status and poor perfusion, begin high flow O2, and then establish IO-IV access according to PALS. And then if no hepatomegaly or rails, crackles, then you're going to push 20 mLs per kilo of isotonic saline boluses. And then obviously we're going to reassess after every bolus up to 60 mLs per kilo with improved perfusion. Obviously in that reassessment, we want to assess, is what we're doing working and improving, but also are we hurting? So we always want to reassess for fluid overload, rails, crackles, hepatomegaly. And then of course we want to correct hypoglycemia and hypocalcemia and beginning antibiotics. And ideally that should happen in the first 15 minutes. I know some of you are probably laughing right now, but that's the ideal time frame that we're looking at, right? So what happens after that? If we cannot increase our perfusion or blood pressure or bring our heart rate down with fluid, then we're in fluid refractory shock, right? So ideally, we've already have IVIO access. And then for children who present in cold shock, we preferably would like to start with epinephrine as our first line pressor. And you have the dosing there. But of course use your resources, but it would be 0.05, 0.3 mics per kilo per minute. And then I don't think we really talked a whole lot about getting central access, but as far as using ketamine for sedation and pain. And then talks about titrating our epi, so knowing what your normal blood pressure is that you're looking for here is pretty important. And also, I think another important thing to point out on here is it says that begin peripheral IV-IO inotrope infusion. So don't delay, and I don't know how you guys work in the adult world, but I wouldn't delay starting an inotrope because you don't have central access. You really don't need central access for your initial starting of IV. And then we have the dopamine, if the epi is not available, would probably be your second choice. That's usually pretty available. Most EDs, most floors have like the premixed dopamine bags. And then certainly if they're in warm shock, norepi would be your first choice pressor at this point. Or if that's true, if that's all you have to get started, then I would go ahead and start that. And we've got the dosing on there. It's a little bit different, I think, than a whole dosing. Okay, so how are we measuring their response to treatment? Getting a lactate, and I don't know if that's something you guys can easily do in the ED or not, if you send it off or if you can run iStats. Obviously, we want to be monitoring urine output. We want it to be greater than 1 ml per kilo per hour, or at least 1 ml per kilo per hour. Our blood pressure, cap refill, pulses, mental status, all that good stuff. And then heart rate. So keeping a close eye on those, on all those vitals. Okay, that was really, really quick review of what we spent 2 whole sessions talking about. So certainly if you guys have any questions, you know, we can open up the floor for that before we start talking about kind of what everybody's doing for ped sepsis. Any questions on treatment, recognition, I think when talking about pediatric sepsis, one of the really important things, because we are pretty reliant on our vital signs, and for those of you who've worked with us for a while, like, we do have resources for you, but does everybody feel comfortable looking up pediatric vital signs or knowing pediatric vital signs and what's normal for different age groups? Or what resources do you guys use? Anyone or everybody?
Well, I'm sorry, this is Michelle. I thought I was on mute. Forgive me. Actually, we have badge buddies. We have some nurses that, you know, we have a realm to new, novice to experts. Some nurses are experts in pediatrics and know that, but we have resource, and I believe they're your pediatric badge buddies that came out with PICO.
Yep.
When PICO came out.
Yes, they are.
Okay. And those are just.
We use yours as well in Anderson.
Okay. All right. Does anybody need resources for that? I will take your silence as no.
Again, this is Michelle. If you have them that for free available, you know, we get new staff all the time. They could use new badge buddies.
Okay. All right, so kind of digging into a little bit as far as, like I said, this discussion today is really going to be kind of led by you guys and what you want to talk about. And so I kind of thought we could start with talking about what current practice is for pediatric sepsis in your EDs. And if you guys have any algorithms or protocols you currently utilize, or order sets, or what resources are you guys currently using, if you're using any right now, if a pediatric septic patient were to walk through the doors of your ED right now?
I just want to make it easier for everyone, because the way I treat sepsis in our institution as a children's hospital is literally when I have a new septic shock patient, the first question I ask my fellow when they are, you know, resuscitating them, where are we with the timeline and how much fluid they got? And those are like magic questions we always ask. We said, oh, we got 3 bowls of 20 ml per kg and it's been 20 minutes. So my second question will be, what anaerobic supports they're on right now? And some of them will say none yet. I'll ask why not. Some of them will say, you know, we have epi starting at this dose. Then third question will come. So I know the algorithms sometimes are hard to track within that timeline, but realistically, you know, as long as we have the flow of it, the timeline may be a little bit more relaxed, you know, in the ED compared to the PICU that we already have the patient with diagnosis. You guys will have them up front, like coming a patient with lethargy. Well, by the time you get blood pressure, it may be a little bit delayed. I'm just saying, like, think about it that way. Is actually the logic flow of the algorithm is very helpful. If you apply it with a timeline, it's even more helpful and beneficial, but you can always follow the logic itself of it. So I'm curious to hear about how you guys treat, you know, sepsis in your ED. Is it going to be in the trauma bay or in the regular room when they're coming with hypotension and shock? Or are you going to, you know, activate certain, you know, algorithm or certain teams to take care of this patient, to tag team the patient? Like, I'm just curious to hear from everyone.
At Hendricks, it kind of depends on if they come in by ambulance, if we have enough information, if we feel like it's looking like a shock patient, peds shock, we would go to our peds trauma room. I will say most of the time they come in through the front door. So we have been pushing in our triage classes that we've been instituting. It's something new. We are sending people through our triage class because we want them to recognize immediately a child that is lethargic or isn't acting appropriately. So we push to look at that mental status, see how they react when we try to get a quick weight on them, get your hands on them, feel, are they hot, are they cold, are they responsive to you, if you can get some vital signs. And then we use the same thing, we use your badges, and that's what we've been pushing to educate what is correct vital signs or normal and abnormal. To kind of guide us for our ESI, whether we're going to put them up front or we call a pediatric alert. And that gets where we do that teamwork, where we get a bunch of people all at once in a room. We had a case last week where I had a 8-weeker that was coming in that was rectal temp of like 102.8, and I got a heads up from the pediatrician's office. So I kind of had all of my stuff ready to go. I didn't start them in the trauma room because the EMS called and said this baby was still awake, alert, responsive. He was fussy, irritable, kind of had that lacy mottled head to toe look to him. Did have that high of a temp. So I immediately started, I did a scalp vein because that was going to be the easiest access for me, especially when they're modeled like that. You're not going to be seeing shadows or anything with that. So we went ahead and did that, and we did draw lactate. We did draw our blood cultures, our labs. We checked a quick dex on him. He was okay. He had had vomiting. It was kind of an odd situation. He had had vomiting the night before and throughout the night with this fever. But family, he had no signs of URI, but family had URI symptoms. So we were very quick to get the fluids in, and that's something new that Dr. Farman and a whole group of us kind of worked on getting an order set put together for the docs, and they utilized that, and we did the fluids in 15 minutes or less. And with this little pumpkin, he turned around pretty quickly after. He ended up getting 2 boluses, but we kept him, started him on antibiotics, couldn't find a source, but because he was so young and everything, till we could get those blood cultures, he got admitted. But his re-eval within probably, I'd say, maybe 30 minutes to 45 minutes from me starting the IV and giving those 2 boluses and checking him, he even started to take Pedialyte and was keeping it down. There was a massive change in him. Cap refill was great. He didn't have this lacy mottled look anymore. Fever started to break. We gave rectal Tylenol because he was vomiting up all the Tylenol, I guess, at the doctor's office and things. So we utilized those new order sets. We went ahead and did our fluid bolus. We started antibiotics. His pressure improved. I had an immediate blood pressure, and then I just kept taking that. That is part of the order set that Dr. Farman had created too. We have to recheck every 15 minutes, blood pressure, heart rate, respiratory rate, pulse ox, mentation, and that's something we just pushed through with a lot of the nurses in our recent staff meeting too. So.
Wow, that's excellent, Lauren. Kudos on the scalp IV. That's pretty impressive. So is your order set, is it specific to like fluid resuscitation or pediatric sepsis, or just curious?
Yeah, so the order set itself is, we have Epic, and so a lot of the challenges that I'm sure that are faced by all hospitals, whether it's downtown or elsewhere, is how do you translate order sets that are developed by folks who work on the floor into something that's applicable to the emergency department, because the EMR modules are just different, you know, from one place to the next. And so we call them quick sets, and it's kind of divvied up, and we've got something that says it's fluid resuscitation, fever, and so it's got a lot of the sepsis stuff in there. We have it subtitled as sepsis. So if you have someone who truly looks septic, you kind of choose from column, let's say C, but if they just look volume depleted but not necessarily septic, you can choose from column A. And at least that gets the ball rolling because we don't know whether they're going to be admitted at our hospital or transferred. So some of the things that are built into an inpatient order set don't always necessarily translate the emergency department setting. So I think it's our best workaround that we have at this point.
Yeah, that sounds great. That's pretty impressive. Lauren, how did you guys give the fluid? Did you do push pull, or did you run it on pump?
I did the pump, and it was a good enough IV. I just ran it in 10 minutes. So, yep.
This is a very exciting story, actually, and very good to hear this from our, community partners when it comes to pediatric sepsis. Unfortunately, pediatric sepsis is still one of the leading causes of morbidity and mortality in children overall. So anyone else would like to share with us a similar story or any other events you guys have had in regard to sepsis where you use or did not use protocol. Again, it's open podium for everyone. We like to hear from you guys about this.
Dr. Farman again. I can give another example, and this is from years ago, kind of before we have some of the kind of pediatric focus that we have currently. So I can speak to the way that it doesn't always go well. And I think part of that is inherent to the nature of working in a community hospital at times. The geographic nature and the way that triage is performed will oftentimes lead to a destination for a patient that may not be ideal. So I have certainly seen patients, if they don't come in by ambulance, who come in through the front door being held by their parents. They get initially triaged and they get placed in a room elsewhere in the emergency department that may not necessarily have the resources. And one of the things I've encouraged the physicians to do is, if you identify a patient who kind of snuck through the triage process as being more sick, to then move that patient or direct the staff to move that patient to our resuscitation room. Because when I first started at our hospital 10 years ago, I wasn't quite as forceful with doing that. And from a physician standpoint, that's something that you kind of have to learn with time. But I didn't even know if I completely understood the nursing ratios. So if a nurse is assigned to one of our back hallway rooms, they have a couple rooms that they're in charge of, and they may not be able to go and attend to the child as quickly as you think that they need to be attended. You're wondering, well, why isn't this getting done? Why isn't that getting done? But if you recognize someone as being critically sick, it's imperative to move that patient to a location where they can get the resources that they need, one-to-one nursing and those other things that are important to resuscitation. So as you guys go travel around Central Indiana, I would say that that's one thing that I've learned from my personal practice to encourage other physicians is to don't let the initial triage be destiny. Occasionally you have to make adjustments, and that allows for better resource allocation.
Yeah, that's great. Thank you. And that obviously Kamal and I don't work in the emergency department, so some of the logistical stuff is things that we don't know to share. So that's why we're all here together. Has anyone else experienced that, where a kid was triaged? I'm sure you experience it all the time, but specific to maybe sepsis, or a really sick kid was triaged, maybe under triaged and put in a room like that, and you've had to move? Or does anybody have like policies on how that works? Or I'm curious because I just truly don't know.
This is Dr. Michelle. We at Community, first of all, let me say we have lots of opportunities. But hey, we partnered with you, so at our North Campus, so we're getting there, right?
Yeah.
But we really hit hard. I know last year for those neonates that come in and have fever, or if the parent says that they've had fever, to take the parent at face value of what they're saying, even if whatever method we took the temperature at that time says that they don't have, that we need to take the parent for face value and up triage that patient versus under triage in that patient, because you can always move them down quicker. Now, we certainly have, when you get above our neonates and stuff, especially during like RSV season, cold and flu season, these kids that come in with runny noses and things like that and just have a little bit of a fever that are toddlers or more. I mean, sure, we've been caught with that where we thought, oh, this is just a simple otitis media, and then they've been sick, and then we've had to move them into the shock room. And also with that, we've had where in triage, we haven't, because of how the triage was set up and we do immediate bedding, they thought they had time and didn't unwrap the baby to look to see what respiratory was looking like, right? They're in the car seat, mom carrying them in, and they didn't unwrap it to do that quick look-see. And we've gotten caught with that. But we've done education around that now about, you know, you got to do a look-see of these kids before you even send them anywhere.
Okay, great. Thanks, Dawn.
And speaking, like, in accordance with what Dawn was saying too, that was a huge thing we were trying to push just to educate our nurses to, exactly, to unwrap them and take them out of their car seat, because you could easily have a baby all bundled up and not realize. And we had a baby last year that came in like, whatever the complaint was that the mom signed in with was very vague and didn't, like, it was like a cough or something. And luckily, we weren't busy out there in triage, but we could easily have 10 or 12 people to triage through at our busy time of year. And luckily, thank goodness we didn't, because this one was one that went to the peds trauma room because they were blue and completely unresponsive in their car seat. So, and the baby had been sick, had been running a fever, but at this point stopped eating and wasn't nursing. And it was a neonate, and ended up having to go in there, and we had to warm this baby whose core temp was like 93.7. So it had deteriorated for quite a while, but poor mom looked exhausted, had other kids, and just was very despondent and disconnected. And I think sometimes you don't realize that moms that are postpartum, or even up to 6 weeks or so, I mean, that's when they can hit hard, and moms are going to be not maybe giving you everything you need to know. So definitely we push that in the triage class, and we even quiz them as to, where would you go with this patient? If this person presented, what room assignment would you make? Because that's huge. Like Dr. Farman said, you can be busy and not get into your room. So if you aren't going to use your Vocera and your alerts, how is anybody going to know there's a sick child? So we've been pushing so hard to get that, to have a very quick response for these kids, so that we can get onto that, because that 15 minutes, like you guys were saying, it can be gone in 2 seconds and you haven't even seen them. So it's much better to take them up front, call, if you have an alert system, do something like that, or get somebody in there quickly to start this, because you're right, time is of the essence with these kids. So.
And that's, I've heard a couple people bring up alert, or we have a pediatric alert. Does everybody have some sort of, I don't know if it's the same as, I would assume it's not exactly the same as like calling a code. I know we've been to some sites that have a pediatric alert, and that brings in like the physician, pharmacy, RT, all that. Does everybody have that, or what does that look like for everybody? Because it's nice to have extra hands on deck when you have a sick kid.
At North, we do not have anything in place like that at this time.
Okay.
But we do have at community, not specific for peds, but a team alert, team activate.
Okay.
And there's some criteria for that. So if we had a critical patient that came in, or a patient that the nurse was highly concerned on and wanted the physician at the bedside, we activate a team activate, and then designated people come, including the physician. Now, that's not specific, that's general for the entire population. You can call a team activate for adult, you can call a team activate for a peds. And then we have a team alert, which doesn't bring the physician to the bedside, but brings everybody else to the bedside.
All right. And does anyone else have any, sorry.
Oh, yeah, all right. We don't have one in place, but we're working on it. We have it programmed into our alert box, but are just working on finalizing criteria and so forth.
Okay, cool. And is that going to be specific to pediatrics, or is it going to be like any decompensation?
No, specific to pediatrics.
Oh, cool. Great. So I guess, does anybody else have any algorithms or protocols that they use specific to peds sepsis? I know a lot of sites we've been to have had adult sepsis protocols or algorithms or order sets. As usual, we're always a little bit behind on the pediatric side with some of that stuff, but does anybody have anything in place besides our friends at Hendrick? or anything that they, like, is their go-to if they know they have a septic peds patient?
At Hendricks, I know that they're currently in the process of building pediatric sepsis protocols and everything. There's a whole team working on that, and they're getting closer with that. I don't know how close, because I don't attend that, but they are trying, and because that is something they've been working on for some time, and I know it's becoming more and more, prevalent. So I would say right now, I think that the ED, the order sets we have in place are a really great starting point. I mean, if the fluid boluses weren't working, we would, the physicians would take that next step up, and they have before on kids. So, and we had the little pathway you guys had up there earlier from PCOM. We do have that. So that's always a little resource sheet we can look at if we need to too. So that's available for us. But as far as something in place currently for pediatrics, it's still in the process. I don't know.
Yeah, for smaller hospitals, so many of these end up getting transferred out, and it kind of gets to the module and EMR issues where if you spend a lot of time building a sepsis protocol that's never used because they never stay at your hospital, then it's kind of hard. And sometimes by the time you get to the third or fourth step down the algorithm, really the patient should probably be at a tertiary care center already. If we're getting to the point where we're talking about central lines and stuff, I'm like, I haven't done my job right of identifying this child early. So I don't know.
What about like medication resources? Because I know that is usually a big, people are always scared. They're, you guys obviously, I would not commit this stuff to memory because it's not medications that you're probably giving all the time. Do you guys have any like go-to resources? Is pharmacy involved? I think that's usually a barrier that people kind of mention. If people have apps they use or anything to share?
We have pharmacy oversight for any medication that we order on a pediatric patient. I think there's an automatic pharmacy check even on things like saline. There's something that triggers the pharmacist to at least double check our dosing to make sure that we're not out on left field.
And we carry all of the inotropes. We have access to dopamine and epi drips and everything pretty quickly. So if we have them, some of them in our department, and if we don't, we can try to push and get, we call immediately and tell them we need it down there. And it's gotten much better as far as like response time from pharmacy. And if you call a certain alert, they should arrive. So then that gives you even quicker response, I think, if we get to that point, we need those meds and that, so.
About everybody else, any go-to resources?
And we would involve pharmacy, and they will come and help us in our shock room.
In addition, we get great support from, especially on our North Campus, from our PEDS unit and from our NICU unit. All of our NICU units are great if we would call them and say, we got a sick baby, can you come help us? But especially on our North Campus, we get support from our PEDS unit should we need them. We're on the same floor, like next door neighbors to each other.
Oh yeah, that's right. It's just right down the hall. Okay. Any other resources or anything else that you guys what your normal process would be if you had a sick peds sepsis patient come in? Can you talk about or share? Yeah, just to touch, and you guys, if you don't want to discuss it here, then that's totally fine. Feel free. I think everybody has my contact information if there's anything you want to follow up in, but I don't know if anybody has noticed any gaps they have in their ED, especially with like equipment. We kind of talked about access to medication. We found that a lot of EDs would not stock an epi drip on their floor. It's something that would come from pharmacy, and some people, you know, they're like, oh, pharmacy will have it to us in 10 minutes, and sometimes it's a half an hour, which can be a problem. Or access to resources, and a big thing is a lot of people have resources, but not all the staff know about it or where to locate it. So I don't know if anybody has noticed any of this or is currently working on anything they want to talk about.
Actually, I have a question for you guys about, with the patient with sepsis who come to your ED and, either get admitted or go to the ICU or transport to other ED. I'm curious about, do you guys have any mechanism of tracking these patients, like over time, for example, over a year or two? You'll see how many patients with septic shock you've had. You see if you have any patients that have certain issues that you can address. You have like a tracking mechanism of the care you provide to sepsis in general, given that there's more and more sepsis campaign and guideline and awareness campaign happening, and a lot of these kids, and indeed more than 90% of pediatric patients who are acutely ill are seen initially at general or community emergency department. So I'm curious to see if at the front line, if you guys have any mechanism or even like a brilliant initiative to track the quality of care you provide to these patients or not. I'm just curious to hear from everyone.
I don't think at Hendrix we do. Probably a number of them do get transported out. And if we get follow-up, that's great. A lot of times we don't. Some of our doctors, they kind of call or look in Care Web and kind of stay on things, but we don't hear from the proactively from the institution that we sent to.
For adults, we have all that data for a hospital. We get tracked, and then we have people who are kind of dedicated to tracking those numbers because they're tracked by the government. So it's one of those things we have to track. For pediatrics, I don't think we have any of that.
Yeah, I feel actually for us as a children's hospital, we haven't done, in general, enough good job to keep you guys in the loop in regard to these patients who come to us from you. And I look at it in both ways. Like if we think that there's something should have been done additionally or differently, you should guys hear about it from us, in a collaborative way. But more important than that, if something actually went well and we are we're very, happy and excited about the way things well with this patient in regard to management, we should re-emphasize that and reinforce that with you. I feel like there's somewhat of a communication gap in there between the pediatric academic center and the community partners in regard to keep each other involved and, updated on the care provided to the most acutely ill and injured children. And sepsis patients are probably the most important category among all other categories. I'm always curious about if there's like a certain way. I mean, it's my dream probably in the next 20 years to have a well-structured community of practice network between us and all our community partners in the state, where actually we can, you guys have easy access to track the progression of these patients. Have a certain platform that will update you with the main highlight of these patients that everyone will be able to access for their own patients and capture the main theme of the patient quality of care, the patient outcome, how the patient is doing. But I think a lot of the time we don't hear about how things evolve afterwards, especially in the ED. You guys see patients, stabilize them, send them home, or send to the ICU. While in the ICU, we have more of a continuous model of care because they don't go anywhere except if they're survive and go to the floor, or unfortunately if they don't survive, it's a different story. So I feel like we have more responsibility to keep you guys involved in this. I'm curious to hear about you, since you are the stakeholders of your EDs. Is that something you guys want to be aware in the future? Is that something we can think of how to keep you updated and somehow? Or what do you think about the concept itself?
I think it'd be very welcomed. I know that from my personal practice, St. Vincent's does a good job on the adult population of contacting the ER physician if we were to transfer them a heart cath case or a trauma 1 case. Typically speaking, after the heart catheterization on a STEMI, we get a call back. And we don't work with St. Vincent's much, but they would typically call back and say, this was the result of the heart cath, and you get that information that same day. If it's trauma 1, usually someone from their trauma center will call you back within a week to give an update on kind of how that particular patient did. From a kind of a macro standpoint, I think that would be something very useful for the community hospitals that are partnering with Riley. You could even have a database whereby you send out just hey, these are the 10 sepsis transfer-ins we got this month. You don't even have to say which hospital they came from, but you could say, what are the outcomes on these cases? Were there any complications? That sort of thing. I think that even if those cases weren't specific to your individual hospital, if you could look as a physician director and say, hey, Sullivan County did a great job on that one, or man, there was a gap from that hospital in Illinois. Okay, I won't throw anyone under the bus, but then you could at least use some of their successes or failures as things to learn from, because you may not actually have that many total patients, but there's still things to be learned from each of those cases.
Absolutely, I totally agree. I really would like to echo what you've said, and this is exactly what I have in mind, is like some kind of like platform or database for us to share with the necessary and relevant information for everyone to know about. And this come back to what Erin was saying earlier, definition of community of practice. And I really believe this will keep everyone, including us, engaged and involved, and sustain the model that we're trying to keep building and adding up to, and keep it sustainable among all our partners. So it's something really to think of, and the more we do this, the more we're learning about it, and it's like an eye-opening to us and adding more responsibilities and commitment to us. So I'm glad actually you brought this up as well, and I like the lens you use to look at it. It's very, very important to think about somehow a format to get this done in the future, hopefully. Yeah, there's a question about if the work going in Indy with at Riley with some sepsis guideline algorithm and overall quality improvement for sepsis. I know our ED colleagues here at Riley ED are working with the QI committee at Riley to design and implement sepsis quality improvement for our pediatric patient with sepsis coming to the ED. I don't know how much progress is made on that. I think one of our hosts 3 sessions ago, Brian Wagers, he is the main lead person on that project. I will get some update from him about this. But I know this has been the focus of his academic career and his passion in quality improvement about pediatric patients with sepsis. If you guys want to know more in detail about this, I'm more than happy to get actually maybe a 1-page quick synopsis or snapshot about what's the initiative, what is it about, and probably have a little bit of how relevant or applicable that can be to you guys. But I strongly believe when these EDs, like your EDs, see the majority of these patients up front, a lot of things we do here are applicable as long as we are able to tailor them in a certain way to make it relevant to your practice. So I will have that on my list to do and share with you guys what we find out from our ED here at Riley.
So kind of to go along with that, if anybody is interested in working on maybe identifying some gaps or looking at, sepsis overall is, you know, it's kind of like a beast to tackle, I feel like. But if anybody wants to focus on just, you know, like the fluid resuscitation piece of things and push-pull method and kind of doing education with your team, you know, please let us know. We would be happy to assist in any ways that you guys need us to. We have a lot of resources already that we're happy to share. And then certainly Kamal can get some information about the QI project that Riley ED is working on, and we can send that out to the group as well if that's something people will be interested in. And I know Lauren had kind of mentioned you guys have a sepsis team there at Hendricks that's working on stuff. Does anybody have any ongoing work for ped sepsis in their ED, working on order sets, resources, anything currently, or don't know?
This is Dawn. We did a big push for our adult population. Obviously, at community, for the most part, pediatrics is only about 20% of our population. And then of that 20%, I couldn't tell you what percentage are really our sick kids that aren't treat and street kids. I would say probably less than 5%, and you probably see all those. I do know our NICU worked on something, but specifically for peds, no, we have not.
Okay. Well, if it sounds like something anyone would be interested in working on, or if you have other staff in the ED that are interested and passionate about it, I know a lot of people in the general ED get voluntold for some ped stuff, since that's not everybody's passion. But certainly if you guys have interest, please don't hesitate to reach out to us. That's what we're here for. Really happy to help in any way. And I know as Dawn kind of alluded to, this is really can be a low volume population that you guys see, but it is a high acuity, and there's a lot of things that we can all do as providers to kind of decrease our morbidity and mortality in these kiddos. So really happy to help any way that we can, anything you're interested in. Any other comments? We, We had some stuff on here like last time about smart aims and QI, and if anybody is, I am not a QI expert by any means, but if anybody's interested, I'm happy to share some resources about that with you guys. Okay, I know I'm always harassing you guys about surveys, but here's the link, and I will also send it out in the email so that you can just click on it. It's the quick, pretty simple survey that we've been doing for both the status and the sepsis one. But if you could please provide us any feedback about the entire sepsis series, if there's anything you felt we didn't have, anything that was helpful, we really appreciate it. Again, we're still kind of learning as we go along. So it really just takes a couple minutes to fill out, but we really appreciate any feedback you guys have. So again, I will send this out with there will be the link to the recording and then the link to the survey. I'll send it via email to everybody. And then as always, if you guys have any questions, please feel free to contact me. My email's on there. I'm happy to help, and if we don't have the resources, we'll find them for you. I will provide the link for this session, the recorded session, so that if there's anyone else on your team interested in watching, please feel free to share it with them. So I had sent out a survey a couple weeks ago asking what you guys were interested in hearing about next, because this kind of ends our first two sessions. We had the status epilepticus and now the sepsis. And so I didn't get a ton of response, but the majority of people wanted pediatric respiratory. So I thought it was very appropriate coming into this flu RSV bronchiolitis season that we go ahead and talk about respiratory stuff. So next session will be October 17th at noon. We're back to the third Thursday of every month at noon. And we're really going to focus on signs and symptoms of respiratory distress in children, what to look for, some tips and tricks, and then we'll talk about some of the pathophysiology of common pediatric respiratory illnesses, so stuff like bronchiolitis, asthma, fun things like that. So, have you guys been seeing some RSV, flu, anything yet? I picked up a couple on transport.
We've seen a couple flu actually already here at Hendrick.
Yeah, I think they're predicting a pretty rough winter.
I think so too.
I gotta get my shot.
I got mine. Pretty much gave it.
Tom, I will get you some of those resources you asked for, and if I don't email you, just shoot me an email because it just means I forgot, but I have it written down. So I will get you resources.
Erin, will you be bringing out some more badge cards next week to the session?
Yes, I will.
Okay, perfect. I figured you would. Thank you.
You're welcome. All right, and if does anybody have any questions or any comments or anything?
Thank you, guys.
Great. Thank you, everybody, for joining.
Thank you.
Thanks. Have a good day.
Thank you.